Yes.
Okay, you can.
Audible.
Yeah, you're audible. You can start. You can start.
A wonderful good evening to one and all present here. I'm Mansaratmika, a second year medical student. It gives me immense pleasure to introduce Medusane, a platform that has rapidly grown to become a trusted educational partner for medical students across India. Our mission is simple to provide accessible, high quality educational resources that empower students to excel in academic and professional journeys. With a vibrant community of over 23,000 YouTube subscribers, Medusane has made a significant impact in areas like clinical case presentations, theory lectures, MCQ discussions, career guidance, and skill development. We're constantly evolving to meet the needs of our students, whether they're preparing for competitive exams or seeking to build strong foundations in medical practice. One of the things that makes medicine stand out in is our commitment to mentorship. While there are numerous platforms offering medical education, medicine uniquely emphasizes personalized mentorship. We aim to provide students with daily guidance, one on one support, and practical insights that go beyond textbooks, helping them build confidence and clarity on their career paths. As we approach World Diabetes Day, we're reminded of the importance of awareness, education, and collective effort in combating one of the world's most pressing health challenges, diabetes. This year, we're excited to present a special lecture series dedicated to deepening our understanding of diabetes from its physiological and biochemical foundation to its management and complications. World Diabetes Day is more than a date on the calendar. It's a global call to action. Diabetes affects millions of lives, impacting not only patients but families and communities. Through this series, our goal is to bring together experts in the field to share valuable insights that will empower healthcare professionals, students, and the broader community to tackle diabetes effectively in the daily practice. Each session is designed to address crucial topics from the basics of insulin function to advanced management strategies, along with the latest guidelines. This initiative emphasizes the role of continuous learning and collaboration in addressing diabetes and aims to equip you with practical knowledge and skills that are essential for improving patient care. We believe that raising awareness and fostering understanding of diabetes is vital in reducing its burden on society. We're grateful to our distinguished speakers and enthusiastic participants for being a part of this mission. Together, let's make this World Diabetes Day a step forward in our journey towards a healthier, diabetes aware world. And today, we're in the 10th session of the series, and this briefs about diabetes and pregnancy, a comprehensive care for mothers in diabetes. And I'll also take this opportunity in wishing Parthiban sir, a convener of Medusane, a very happy birthday. Happy birthday, sir. And over to Parthiban sir, and I'm requesting him to welcome today's speaker. Thank you.
Thank you so much, Mandratmika, for your wishes. And I take great pride in welcoming our speaker of the day, Dr. S. Soundarya, ma'am. Apart from being a part of medicine, actually, I feel very privileged to welcome her because she's a senior from our college, and her name is well known in the campus of our college because she's the girl who got the 12 gold medals. Still, many professors used to talk about her. Welcome, ma'am. We take great pride in having you here. The
Thank,
session is all yours,
thank
please.
you. Thank you very much. And happy birthday.
Thank you, ma'am.
Uh, Thank you, Parthiban sir, for welcoming ma'am. And our beloved speaker, Dr. Soundarya ma'am, is a dedicated obstetrician and gynecologist trained in high risk pregnancy with inclination for imparting medical education. She is a medical graduate from Tagore Medical College and Hospital, Chennai, and has did her MS Obstetrics and Gynecology from JIPMA, Pondicherry. She is also a recipient of the very prestigious Dr. S. Jnanadesikan and Dr. S. Subramanian Gold Medal by the Tamil Nadu Dr. MGR Medical University in the field of microbiology in 2021. Congratulations, ma'am, for all your achievements, and we look forward for a wonderful presentation. Over to you, ma'am.
Thank you. Thank you very much. I'll just switch on the slideshow. Yeah, is it visible to everyone? So, thank you, Medusane, for organizing this wonderful series on diabetes. And thank you especially for giving me this opportunity, because most of the speakers who were ahead in the series were almost my professors, Dr. Jamuna Madam, Dr. Desika Mani sir, Dr. Saravanan sir were all my professors, and I feel really honored to be able to share insights on the same platform. Thank you once again for this. And let us go on to the topic. The topic given to me is diabetes and pregnancy. So let us discuss this in two separate parts. Okay, first one is the gestational diabetes mellitus. That will be dealt in few subheadings like the types, the definition, classification, specific carbohydrate metabolism and the changes in pregnancy, risk factors, stratification, maternal and fetal effects, and what are the screening guidelines we use, and the management. And a second subset, that is the pre-gestational diabetes, that is the population, those are already diabetic, like the type 1 diabetes and type 2 diabetes, and then later on go on to become pregnant. So we'll just discuss the specific complications, maternal fetal complications, and the management regarding to that. Let us try and see that there are not much repetitions. Okay, so a case scenario. A 21-year-old primey at 29-year-old primey at 22 weeks of gestation comes to you with a DIPSI value. DIPSI is one of the screening tests used for screening for diabetes mellitus. Okay, and the value given to of the report is 150 milligrams per deciliter. The cutoff for DIPSI is actually 140, so it is higher than the cutoff. She comes to you with that report. Okay, and she gives you a history that she previously had irregular cycles and was evaluated and told to have PCOD, and she was given metformin for the same. At the time of evaluation, her sugars were tested and told to be normal. Okay, now she's waiting in your OPD. She told she's taken an anomaly scan 1 year back. Okay, and the reports are awaited. Okay, so this is the scenario. So she asks you, what are the risks of me having an anomaly in my fetus? Because I've done an anomaly scan, the report is awaited. I'm anxious to know, will there be any risk of anomalies to my fetus? And then what is the role of metformin in this patient? Because the history says she was given metformin when she was diagnosed as PCOS, and she had stopped it sometime until before her conception. So what is the role of metformin in this patient? What are the associated complications expected in this patient antenatally and during labor and delivery? What is the routine antenatal care of this patient? So we'll go through the entire lecture and we'll get back to the same scenario. We'll see we are able to answer all these questions. All right. And one more scenario, a 32-year-old para 1 live 0 abortion 1 comes to you for preconceptional counseling. Okay, so she's 32-year-old. She has had one abortion and one baby that has not made it. Okay, some death has happened to the baby. So we'll see what is the history. So the first pregnancy was a first trimester abortion, and it was medically managed. Okay. Second delivery was antenatally. She has done some tests and her sugars were told to be high at around 6 months of gestation, and she was started on insulin. Okay, and she was on follow-up at 29 weeks. What happened? She underwent preterm labor. Okay, and baby was admitted in NICU for 1 day, and on evaluation the baby was told to have some cardiac anomalies and the baby did not make it. Okay, so after delivery and discharge, patient was started on clomiprid 1 mg BD, and she's on follow-up. Now she wants to conceive. She comes to you for preconceptional counseling. So how will you counsel the patient? What are the important things you will discuss with the patient, and how will you plan her pregnancy? Okay, what is the risk of anomaly in this particular patient compared to the previous patient? So what are the steps? Now she's had one previous history of preterm labor at 29 weeks. So there is a chance that she might go into preterm labor in this pregnancy also. So what are the steps you will specifically take to prevent another preterm labor in this patient? Okay, so we'll try and see at the end if we are able to answer. All right. So what is gestational diabetes? So we are moving into the subset 1, which is gestational diabetes mellitus. Okay, so the definition is carbohydrate intolerance of varying severity, onset or first recognition during pregnancy. So we'll split this and understand what they're trying to say. So carbohydrate intolerance of varying severity. It means what? Means a glucose load is given to this particular patient. Okay, and we expect her to tolerate that load as a normal individual, but somehow the mechanisms that are supposed to like manage the glucose load and bring her serum glucose levels to normal are either not working properly or not adequate, or facing from or some resistance from the other antagonistic mechanism, so that when this particular carbohydrate load is given to the patient, the homeostasis of the glucose metabolism is not maintained in this patient. Okay. So this intolerance, it can be of varying severity, it can be mild intolerance, it can be very bad tolerability with events like glucose load, it can be anything. Okay. And with onset or first recognition during pregnancy. So this can be due to the various changes in the carbohydrate metabolism that occur due to pregnancy, or she can already be a diabetic who unfortunately missed the screening and ended up becoming pregnant. And then we are finding this during pregnancy. So I repeat, so it is carbohydrate intolerance of varying severity with onset or first recognition during pregnancy. Okay, so this is the definition for gestational diabetes mellitus. And incidence and burden, 5 to 8% in India, roughly. Actually it varies from place to place. Highest is almost 14 to 16%. If you take an international statement, about 16% of live births, okay, are babies born of GDM mothers, and 90% of these are seen in low and middle income countries. So actually, as you saw in the previous case scenarios, there was that patient had one abortion and one preterm delivery. So actually, there is a risk of sudden IUDs in uh, GDMs and even type 2 diabetes. So this is only giving the burden of live births. So apart from these, there can be other deaths also that has happened. So this is a huge burden actually. And I remember my professor telling when she was a postgraduate, when one gestational diabetes case gets admitted to the hospital, all the postgraduates used to run and go see the patient because it used to be such a rare case. They may not see another case for quite some months. But that is not the case today. Now, every third or fourth patient in the ward has a carbohydrate intolerance. We are looking at such a huge burden. We really have to work on this very seriously. Some lifestyle modification, something has to be done about this. Okay? Gestational is not in our hands, but at least the lifestyle adaptations should be taken care of and should be emphasized from a very young age. Okay, so just to see what are the subsections included under diabetes. So now if you see any patient with diabetes in pregnancy, they are classified into two major types. One is the previously existing diabetes. So they're already known diabetics, either type 1 or type 2 diabetes, and be going on to become pregnant. Okay. The other population is the gestational diabetes, which we never had any comorbidities before pregnancy, and then we are finding out during pregnancy. Okay, so that includes a subset of population who were actually pre-existing diabetes but did not have symptoms, so did not undergo any screening, and then during pregnancy we are tracing the subset of population. The other one is the true GDM, which actually did problem occurred and started during pregnancy, and most of it will relieve with pregnancy. So to identify actually the true GDM, postnatal follow-up is also essential, where you will repeat the tests like the glucose tolerance test after delivery, 6 to 12 weeks after delivery, and check if it is normal. So only if it is normal, we call them as true GDM. Okay. And classification. Age-old this thing, we are using the White classification. This is the modified White classification. This was actually proposed in 1990s, and then it was underwent a few modifications and endorsed by ACOG in 2006. 17. So this is a huge table used by all people for the classification. Now, this is based on the simple concept of the duration of the diabetes, severity, and associated vascular complications. Now, let us not get too much into it, only the gestational part. See, all gestational diabetes, according to White classification, are called GDM-A. They come under the class A, okay? And then we have A1 and A2, okay? So, A1, GDM-A1 means it is gestational diabetes, and they have adequate control with diet. That is the medical nutritional therapy and did not require any drugs. A2, GTM A2 means they did not have adequate control with diet and then they required medication. Medication can either be oral hypoglycemic agents or it can be insulin. Anything will come under GTM A2. So what is our target? Like when do we say this control is not sufficient and go on to start OHAs and insulin? According to White classification, it is fasting more than or equal to 105 and postprandial more than or equal to 120. Now, these cutoffs have been lowered. We'll see later what that is. Okay, so as of now, I want you to remember only this. GTM A1 means GTM on diet and GTM A2 means they require medication, can be either OHAs or metformin. All right. And then, yeah, so if we go back to this classification, I want you to realize all these classifications included only the maternal complications, the duration, the severity, the insulin requirements, and the other complications that occurred in the mother. So, no classification, this classification at least did not look at what happened to the pregnancy, what happened to the baby, and what happened to the pregnancy related outcomes. So, then a few other classifications were proposed, okay, so which looked at the pregnancy outcomes, so what happened to the baby, how bad the baby was, and all that. Okay, so the important ones we'll discuss later. So now this is the latest one actually. This is proposed in November 2024. It's just in proposal stage. So they proposed a new type of classification which included 7 subtypes actually. I don't want you to confuse with all this. This is only for the postgraduates. Now I'll just tell you in brief. So if you see there is a type 0. I'll tell you now there's a fasting 1 hour and a 2 hour value. Okay. So if the fasting value is high, then it is T0 high. Okay. And then again T1, T2 is 1 hour, 2 hour value high. Then T1 plus T2 is first and second hour high. T0 plus 1 is fasting and first hour. Then this is fasting and second hour. And this is all the 3 are deranged. Okay. So now this is the 7, these are the 7 classifications. Now, overall, they have grouped into 2, GDM of low risk and GDM of high risk. Okay. So, high risk means they have included the neonatal complications like having a large for gestational age babies, having birth injuries, mother undergoing perineal tears and having increased risk for cesarean sections and all that come under high risk. Okay. Surprisingly, if you see all the T0, actually, the patients having higher fasting values, everybody ended up into being high risk GTM. That is what I want you to understand from this study. All T0s are high risk. Okay. And the others were isolated first hour, second hour, and combination of first hour, second hour alone constituted the low risk. So this study interestingly proposed that having a fasting glucose intolerance ended up having more complications than actually the postprandial levels. Okay. So this is the latest one. It's not accepted anyway. It's just a paper. Okay. And the glycosuria in pregnancy, I'm sure you know what is renal glycosuria. Renal glycosuria means the serum levels of the glucose are below the cutoffs for calling it as diabetes, but we still see some amount of glucose in the urine if you test them at random points of time. So the incidence of this is slightly higher in pregnancy, average of about 16%. And this is because there is a reduced renal threshold and there is an increased plasma filtration rate in pregnancy. The overall volume increases, the blood supply to the kidneys also increases, so the glomerular filtration also increases. So that is another one reason. And there is reduced tubular reabsorption of glucose. So even though the plasma levels are less than the cutoff levels, you can see some amount of urine having glucose. Okay, so isolated 1 or 2 values are not of significance, but persistent glycosuria needs intense monitoring. So we'll see the specific carbohydrate mechanism unique to pregnancy. What happens to the mother in early pregnancy and late pregnancy, and fetus in early pregnancy, late pregnancy. Okay. So early pregnancy in the mother. So what happens? Mother has around the early, say 7-8 weeks. Mother also has a lot of nausea, vomiting. Okay. The hyperemesis can be there. The intake, general intake of the mother itself is less. Okay. And the nutrient supply to the fetus also is quite low. Okay, fetus is just developing. Okay, so it is not stealing all the mother's nutrient supply. Okay, and at the same time, the pancreas also slowly starts undergoing hyperplasia and starts producing a slightly increased level of insulin, and the peripheral tissues are also have good insulin sensitivity because there are no antagonizing hormones at high levels at this point of time. Okay, so in early pregnancy everything is good. Okay, the load, the carbohydrate load is low, and the insulin sensitivity is also good. Okay, so we don't see much of problems in early pregnancy until she is not a pre-existing diabetes. Okay, but if you take a look at late pregnancy, so what happens? So actually, the pancreas undergoes hyperplasia and produces higher amount of insulin, but a lot of this functionality of this insulin is antagonized by the hormones secreted by the placenta itself, like the human placenta, lactogen, estrogen, progesterone, everything, cortisol, everything antagonizes the insulin action. Okay. So because of this, there is a slight reduction in insulin sensitivity and there is a relative insulin resistance. Okay? And also, what I want you to know is now the demand of the fetus is increasing in late pregnancy. Okay, so in a normal individual, the substrate for metabolism is glucose. Okay, so now if glucose is not available, a normal non-pregnant can next step will be glycolysis and then the gluconeogenesis. So gluconeogenesis can use either ketone bodies as substrates or can use amino acids as substrate. But what happens in pregnancy? Preferentially, when a mother takes a meal, all the glucose is spared for the fetus. Okay, for the metabolism and growth of the fetus. Okay, and the amino acids are also shunted preferentially to the fetus for the growth of the fetus. Okay, so now the mother's body is not able to use both the amino acids and glucose as substrates. Okay, so only a minimal glucose is paid for the mother and lot of ketones are available for metabolism in the mother. Okay. So normally in a non-pregnant individual, when do you see such high ketone bodies? In a state of starvation. Okay, but in a pregnant woman, even a very few few hours of starvation can also accelerate this ketosis because the supply to the mother is actually ketone bodies. Okay, so as you can see in the picture, there is increased lipolysis and increase in adipokines. There is decrease in insulin sensitivity. Okay, so this is what I want you to remember. Now look at the fetus in early pregnancy and late pregnancy. Okay, so in early pregnancy, what happens? You should remember the fact that insulin cannot cross the placenta. Okay, be it the endogenous insulin or the exogenous administration of insulin, insulin does not get transported through the placenta, and this insulinase also destroys the insulin. Okay, so but glucose is transferred across the placenta to the fetus. So in early pregnancy, so whatever glucose is there in the mother now gets shunted to the fetus also. So fetus has high glucose in the serum. Okay, so this can like how it causes in the adults, it can cause free radical injury and oxidative stress in the fetus also. So early pregnancy having very high uncontrolled glucose can lead to anomalies in the fetus because of oxidative stress and free radical injury. Now, if you take late pregnancy in the fetus, the pancreas of the fetus gets almost fully developed by roughly around 10 to 12 weeks, and it starts secreting insulin from like 16, 18 weeks, and the feedback mechanisms are also fully functional by 20 weeks. So 20 weeks and beyond, when mother has very high serum glucose, that when that glucose is transferred across the fetus, the fetal pancreas is able to sense this, okay, and starts to produce a lot of insulin. So now the fetus, apart from receiving glucose, also has a surplus supply of amino acids, ketone bodies, whatever it wants is available from the mother. What happens? High insulin levels in the fetus causes like a lot of insulin dependent growth in the fetus. So the fetus goes on to have a lot of body mass and visceral fat, okay, and has higher body weight, okay, and also has increased erythropoiesis and so on. Okay, so I wanted to know, in the fetus after 20 weeks, having high glucose load leads to macrosomia. Okay. Then risk factors for GTM. So not everybody gets GTM. So from the history of the patient, what do you want to know? You should know the age of the patient, whether she previously had any history of diabetes mellitus, any previous baby with macrosomia, birth injuries, stillbirth, previous history of PCOS. Okay, so PCOS is a risk factor for GTM. Then pregnancy-related factors. Pregnancy-related factors means these have occurred already, and now you're retrospectively thinking, will this patient be a candidate for GDM? Should I test her? Okay, so multiple pregnancy. Okay, so it's instead of one fetus, it is two fetus with increased surface area of the placenta, and so the trouble also doubles. So, and recurrent vulvovaginal candidates, recurrent infections can be urinary tract infections, local vulvovaginal infections. Okay, and obese patients, and then patient having fetal malformations. Now you're thinking, okay, did I miss having high sugars in this patient? And polyhydramnios. By polyhydramnios, fetus also has a lot of circulating glucose. Okay, so it retains a lot of water, urinates a lot. Okay, and so the amniotic fluid level increases. Okay, and associated preeclampsia. When all these are there, you will go back and screen her for GDM. These are the risk factors for GDM. So now risk assessment, we categorize the people as low risk and high risk. Some classifications also give intermediate risk, but it's not of much significance. So low risk means age less than, I'll read that here for you. So age less than 25 years, okay. Low risk ethnic groups, okay. By ethnicity itself, all Indians and Southeast Asians, we are all under high risk only. So low risk ethnic groups and no previous history, as I told you earlier, no bad or obstetric history, no previous stillbirth, no previous macrosomia, no birth injuries and all that. Okay, so only those population come under low risk, and especially there should be no family history. Okay, so no diabetes in the first degree relative. So any of these comes positive, actually, then we categorize them as high risk. So most of us have a family history of diabetes, okay, and by ethnicity we come under high risk. So all Indians need to be. This was specifically proposed earlier to as low risk and high risk to reduce the burden of screening. So all low risk populations were initially not screened, telling that the risk of diabetes was low. Okay, and only the high risk population was screened. But later on, we found out that gestational diabetes occurred, like when gestational diabetes occurred, roughly around 15 to 20% had low risk factors. Okay, so now we have switched on to universal screening, so we don't actually risk stratify them as high and low risk. Okay, so what is the importance of classifying? Why should we actually try and find out the GDM population? If not, what will happen? So to the mother, we are seeing persistent glycosuria and it attracts a lot of infections. Okay, so recurrent urinary tract infections are possible and vulvovaginal infections are possible. Then there can be associated gestational hypertension, preeclampsias and cardiovascular diseases. They can have metabolic syndrome later on. Okay, and during pregnancy, risk of preterm deliveries, increased risk for a cesarean section, perineal injuries because of delivering a big baby. Okay, and they can have prolonged labor also. Labor dysplasias are possible, and because of delivering a bigger baby, they can have atonicity and postpartum hemorrhage, prolonged hospitalization. Infections. Then the fetal complications, short term and long term. So short term complications, because baby has a larger birth weight, okay, they can have birth injuries, shoulder dystocia during delivery, okay, and after delivery also the baby can have respiratory distress syndrome. That is because the high level of insulin in the fetus actually antagonizes the proper development and maturation of the lung surfactant. Okay? So these babies tend to have respiratory distress at delivery. Okay? And neonatal hypoglycemia because once delivered, there is no supply of glucose to the fetus through the placenta. So immediately the glucose supply to the fetus is shut down. But the circulating level of insulin is very high in the baby in accordance with the maternal serum insulin. So this insulin takes a little time to get degraded. So until then, the insulin keeps acting in spite of not having glucose. So baby can go into sudden hypoglycemias after delivery. Then polycythemia and hyperbilirubinemia are very common because insulin stimulates erythropoiesis, and also GDM and type 2 diabetes also have a lot of placental issues. They have placental edema, villus edema. So relatively it is in a state of hypoxia, so they require increased erythropoiesis, increased perinatal mortality and neonatal admissions. And on long term, they also have metabolic problems, lot of cardiovascular risk factors, and then risk of developing cancers, okay, and also developing type 2 diabetes, type 1 or 2 diabetes, and obesity. And so all these are possible. So we should try and screen all the patients, okay, and treat the GDM adequately. So why the cutoffs? These are the this is the HAPO study, which is hyperglycemia adverse pregnancy outcome study. So I don't want to tell about the study. All I want to tell you is, as I said, the Grisla-White classification only focused on the maternal complication. So this was the landmark study that tried and followed up pregnancies for bad obstetric outcomes, the fetal outcomes, birth weight, the level of fetal insulin, neonatal admissions, perinatal mortality, and everything. And then they proposed, no, you cannot have the same cutoffs as you were having for non-pregnant populations because complications are very higher. Okay. So, so we need to decrease the threshold and have a different cutoffs for pregnancy. Okay. So that based on the HAPO study, we got this IADPSG classification. It is the International Association of Diabetes in Pregnancy study group. Okay. So that proposed a different cutoff. Okay, this is applicable only for pregnancy. Initially, long ago, we got the WHO. It was remodified in 2013. Then we were using the O'Sullivan index. So now it's okay. Now this is a comprehensive table that compares various screening tests. So in India, we use this DIPSI, okay, diabetes in pregnancy study group here, okay, and the IADPSG. I'll tell you about the other two later. So for DIPSI is mostly used in all government setups, okay, and resource poor areas, okay, where no fasting is required for the patient. As and when the patient comes, you give her a random glucose load of 75 grams, okay, and then don't do any fasting samples or other samples. Wait for 2 hours, take a blood sample, okay. If it is more than or equal to 140, label her as GDM. This test is both diagnostic. Okay, it is both a screening test and diagnostic. Okay. Similarly, for IADPSG, is also widely recommended, used in many centers in India, but this requires fasting of about 8 to 10 hours. Okay, I mean, fasting of 8 to 10 hours, and a fasting sample is also required. Okay, and then we take a 1 hour sample and a 2 hour sample. Okay, so these are the cutoffs: 92, 180, and 153. Okay, more than or equal to is considered positive. Any one value is considered positive. Even if one is high, you will label them as GDM. This is a diagnostic test. Okay. In the Western world, okay, they were doing something called a single step and a double step method. Okay, single step screening is actually what we are doing, this DIPSI IAD question. Okay, the double step is where there will be one initial test called the glucose challenge test, giving 50 only. Okay, remember the load is only 50 there, rest of it is all 75. Okay, only when you do the double step method, the initial glucose load is 50. Okay, and you take blood sample after 1 hour, not 2 hours, it is 1 hour and does not require any previous fasting. Okay, so more than or equal to 140, then they subject that patient to a next step. Next step is the 100 grams load. Okay, 100-gram glucose tolerance test that requires a fasting 1 hour, 2 hour, and 3 hour value. Okay, so that has different cutoffs. This was this Carpenter and Houston was endorsed by ACOG. Okay, you don't have to remember all these values. Okay, all I want you to know is in India we use DIPSI and IAD PSG. Okay, DIPSI is very commonly used, especially in PHCs. Glucose load of 75, no fasting required, 2 hour value more than or equal to 140. Okay. So screening protocol, this is issued by the Ministry of Health and Family Welfare. So we follow something called universal screenings, where we screen all the pregnant individuals irrespective of their risk stratification. Okay. So when do you test? Ideally at the first visit. Whenever you get in contact with her, you can test her, but most of the times in first trimester, because of hyperemesis, most patients may not be able to undergo this test. Okay. At the first visit you can do, if it is normal. Okay, first consider if it is positive. So we have done the DIPSI and 2 hour value is more than or equal to 140, then manages GDM. Okay, you've labeled her as GDM. Now, if it is negative, you test her again at 2 different time points. One in the second trimester, okay, at 24 to 28 weeks, and then at 32 to 34 weeks. Why are we retesting her again? Because this is the time when, as I said, all this human placental lactogen, the insulinase, all the antagonistic hormones will be at high levels, and the pregnancy-induced metabolisms will be well established. So even if they get missed during this time, you can pick them up at this time. So it's very mandatory to rescreen them at 24 to 28 weeks. This 30 to 34 weeks is actually variable. Many accept this, many don't test. Okay. So you can ideally remember us 3 time points at first trimester, second trimester, and 1 in the third trimester. Anytime it is more than 140, you label her as GDM. That's all. Okay. Now, after testing her as GDM, what do you want to do? Okay. So first, you will give her something called medical nutritional therapy. That is the new term. Initially, we were calling it as diabetic diet. Okay. Now, what we call it as is medical nutritional therapy along with physical exercise. Okay. So what is medical nutrition therapy? What are the components? We'll discuss later. I'll tell you. So the thing is, once you have diagnosed, you put her on this MNT and physical exercise for a minimum time period of 2 weeks. Okay, this is irrespective of however high the value is. Like more than 200, we generally don't wait. We start her on drugs for safety reasons. But ideally, irrespective of the levels, you should give her 2 weeks of medical nutritional therapy and physical exercise. And then actually ask her to come back with the fasting and 2 hour value. Okay. And if the fasting value is more than 95, okay, more than or equal to 95, and the 2 hour value is more than or equal to 120, then you will require her to be put on drugs. Okay. Otherwise, you can just ask her to continue the same medical nutrition therapy and exercise and follow up her like roughly around every 2 weeks. You can ask her to come with fasting postprandial and keep monitoring. Okay. Or you have to start her on metformin and insulin if it is more than 120. Okay. And then you have to like, especially if they're on insulin, then you'll have to monitor her little frequently, and like maybe twice weekly also, or weekly, until she attains a steady glucose level. After that, you can tone down on your monitoring. You can do it every 2 weeks. Okay. So this is also issued by the Ministry of Health and Family Welfare. This is what we follow. So as I said, when you're giving her any kind of treatment, be it medical nutritional therapy or OHAs or insulin, your aim is to keep the fasting value less than 95, 2 hour postprandial value less than or equal to 120, and all other pre-meals should ideally be less than 100. Okay. And medical nutritional therapy, what the calorie allotted is for normal BMI patients, it is 30 to 35 kilocalories per kg per day. Please remember that alone. And different BMI based cutoffs are there. It's not mandatory to know. Okay. So normal BMI patient, it is roughly around 30 kilocalories per kg per day. And your carbohydrate should contribute to 40%, protein 20% of this requirement, and fat should contribute to 40%. Okay, there are other methods. Plate. They say half a plate of non-starchy starchy vegetables, only 1/4 with carbohydrate, 1/4 with protein. Then vitamins and minerals should be like that. So many methods are there, but you can roughly remember this: carbohydrate and fat 40/40, protein is 20. Okay, and exercise brisk. We advocate this only brisk exercise. If they are preferably doing it every day, very good, or at least 1 hour twice weekly is minimum. Okay, when you put them on medical nutritional therapy. So this is the different BMI based calorie requirement. Let's forget that. Okay, normal BMI is 30 to 35. Okay? And this is the target during the therapy, be it medical nutrition therapy or metformin or insulin. This is your target. Fasting less than or equal to 95. All pre-meals less than. All pre-meals means your before lunch and before dinner you should achieve less than or equal to 100. Okay, and 2 hour postprandial less than or equal to 120. Okay, this is for people on insulin, like you don't want them to go into hypoglycemia at night. So 60 to 90 should be maintained at night. Okay. So OHAs and insulin. OHAs actually what we use is only metformin and glyburide. Only those two drugs are used in pregnancy. Okay, and glyburide or glibenclamide, both are the same. They are associated with not very good outcomes. So we have stopped, or we don't have much experience with that. We are preferring only metformin if we are using OHAs. Okay. So you can start with 500 BD and go on and titrate, and then you can add on insulin there also if required. But always when you start medical management, it is in combination with your diet and exercise. Don't forget that medicine alone does not work anyway. Okay, and so a lot of trials were there. That's okay. And insulin, if you see same regular insulin, what you have for the non-pregnant individuals, we use the same thing. You can use ultra short acting, regular acting, long acting, everything is accepted in pregnancy. There is no problem with that. Only OHS, you have to be very careful. Use only, preferably metformin. Also, the Western world does not, like the American societies, do not support OHS. They directly start with insulin. Okay, I'm not going to the details of how will you titrate and everything. I'm sure the other speakers would have covered earlier. I just want you to know this, that these are the only things used for pregnancy. And obstetric management, intense fetal monitoring, because I said there are a lot of risks associated with this baby. Okay, and there is a risk of sudden IUD also in the baby, because I said placenta also has some problems, and there is a hypoxic environment in this fetus. Okay, so slight metabolic disturbances, slight hypoxia can end up in sudden IUD. Okay, so you want weekly NSTs, doing scans on the fetus for there's something called biophysical profile and Dopplers and all that. Okay, so in other Western side, they even admit the patient by 34 weeks. We don't do it for convenience sake, provided the patient is able to come to you for adequate monitoring. Okay, so all I want you to know is intense fetal monitoring is required in diabetic patients. Okay. So when do you terminate pregnancy? If she is on diet, that's medical nutrition therapy and well control, by 40 weeks. If she is on drugs, okay, either OHS or insulin, deliver by 38 weeks. You can do normal delivery, you can do induction of labor. There is no, it is not an indication to do a cesarean section. So when do you do cesarean section? Only when you suspect that the mother has diabetes and the baby weight is more than or equal to 4.5 kg. That is the only time we offer elective LSAS. Otherwise, normal delivery. Always prepare for shoulder dystocia. Have a team, have a senior obstetrician and a good neonatologist to take care of the complications. Okay. And after delivery also, the risk of atonicity is high. So be prepared for managing postpartum hemorrhage. And if you have given a cesarean section wound, the hygiene should be well maintained. Okay. And the perioperative sugar control should also be very high and very good. Otherwise, she may end up in wound infections. Okay. And the perioperative antibiotic cover is also must, depending on the other risk factors, how much blood she has lost, etc. And oral contraceptive pills, like all contraception can be offered to this patient. Okay? So copper teas also initially they had a fear because it might attract infection, but now that is not the status. You can easily use copper teas. You can use oral contraceptive pills in this population. All right. So as I said, GDM should be followed up to know whether it is true GDM. So you repeat the 75-gram oral glucose tolerance test at 6 to 12 weeks postpartum. And actually, you should emphasize on regular lifestyle modification, weight reduction, and everything. Okay, and lifelong they should be screened with the same 75-gram GDT every 3 years, and 50% may go on to develop type 2 diabetes in 20. Okay. So that's all we have done with GDM. Okay, quickly on pre-gestational diabetes. This cutoffs are the same for non-pregnant population also. Okay, so HbA1c 4.5, fasting more than or equal to 126, and L more than 200, and RBS more than or equal to 200 with symptoms of hyperglycemia, same as non-diabetic pregnant population. So what are the specific problems with these people going on to become pregnant? Okay, so if they have increased hyperemesis, okay, or see, diabetes itself can cause infection, and with every infection, there is risk of them going to ketoacidosis. So every time they have hyperemesis, ketoacidosis, they have under a prolonged fasting, and when we give some tocolysis and steroids for other antinatal purposes, everything may lead on to diabetic ketoacidosis. We should be really having some intense monitoring, okay, and adequate management in place for managing diabetic ketoacidosis. Okay, and there is a high risk of worsening of vasculopathy if they already have one. Okay, and it's better to screen them every trimester, like the fundus, doing a renal function test. Okay, doing an echo at every trimester. Okay, to see if there is any worsening of other vascular problems. Okay, generally these are the same thing, almost common for GDM and type 2 diabetes. All I want to know is risk of abortions are increased in type 2 diabetes, risk of anomalies, fetal anomalies are increased in diabetes, and the risk of vasculopathies, diabetic ketoacidosis are very high in type 2 diabetes. These are unique to type 2 diabetes and not seen in GTM. Okay. The rest are all the same that we have covered earlier. And as I said, fetal anomalies, the risk increases with the baseline HbA1c levels at preconception and during pregnancy. Okay, so cardiac anomalies are the most common in fetuses with of type 2 diabetes mother, of which VSD, ventricular septal defects, are most common. TGA, transposition of great vessels, is the most specific cardiac anomaly, and sacral agenesis is the most specific non-cardiac anomaly in fetus of diabetes. Okay. Macrosomia, as I said, because of high insulin and availability of all substrates, there is macrosomia, especially the cheeks and the shoulder fat, the visceral fat, and everything is very high. Okay, that is Pedersen hypothesis. FGR is fetal growth restriction, generally not seen until there is vasculopathy and the placental vessels are affected. So FGR in type 2 diabetes is very rare, but very risky, and they may go on to have sudden intrauterine deaths. As I said, so just I want you to know baseline. Any normal patient, okay, also has a risk of having 3 to 4% of anomalies. Okay, so the baseline risk is 3 to 4%. But as you see, as the HbA1c level at conception increases, the risk of anomaly increases multifold. Okay, so it's very important that at pregnancy and during pregnancy they have a tight control. Okay, and HbA1c is maintained between 6 to 7 at the time of organogenesis, preferably 6 to 6. Okay. So neonatal complications also already I have explained: hypoglycemia, polycythemia, other metabolic problems, RDS, and everything. And these are the long-term ones. Cognitive development, actually, few studies have noted that they have slightly lesser IQ than the normal fetuses. Okay, and late effects are the metabolic effects, obesity, diabetes, and cancer. All these are studies that have shown. So this is, I want you to, so normally during delivery, When head is delivered, the shoulder follows. Okay, so what is seen in shoulder dystocia? This is the turtle sign where head is delivered and it goes retracts back and hits against the perineum because the shoulder is not able to deliver. Because there is a lot of adiposity around the shoulder. Okay, and the shoulder is stuck at the level of pelvic inlet itself and is not able to deliver. This is the most common thing we see in delivery, having very bad outcomes to the fetus. Okay. So when we try and pull, see, this is the amount of pull and traction will be given on the peaking neck. Okay, when the shoulder actually follows, the relative distance is maintained and there is no much problems to the intervening tissue. But when there is shoulder dystocia and we give a pull, that is when we end up keeping Erb's palsy and other birth injuries to the fetus. Okay, we do a lot of maneuvers, so we can even break the clavicle. They can have humerus fractures. A lot of other birth injuries are common. And so this is the typical look for the infant of diabetic mother, where there is macrosomia, it's a large gestational age, a lot of visceral fat, okay, broad shoulders, and it is slightly, if you can see, there is a lot of reddish, it's all polycythemic. And, okay. So that is the look of an infant of diabetic mother. Okay. So specifically, what I wanted to know is preconceptional counseling. That is very important for type 2 diabetes. Okay. So what are the things you want to discuss? She may have been taking any drugs for diabetes that are not compatible with pregnancy. So you want to shift them into compatible drugs. You should give them periconceptional folate. Okay. And then you should talk about achieving proper HbA1c levels, and you should plan the management for them, how they will come to you, how they will monitor, how you are planning her pregnancy, and everything should be discussed in this preconception counseling. Okay, rest are all the same. We'll give the same dietary advice. Okay, and switching to compatible OHAs and insulin. Specific. So if you have a type 2 diabetes, what are the things you do extra that you have not done for GTM is more frequent visits and intense monitoring. Okay, this is first trimester screening to screen for chromosomal problems. Okay, so trisomy 21, 18, 13. Okay, those are the special tests. This is done in the first trimester, so it's called first trimester screen. Then this is the anomaly scan. Okay, TPA scan is the level 2 anomaly scan that you should do it early, around 18 weeks itself. Don't wait for later, because any anomalies, it can be corrected or terminated, should be given a decision earlier. Okay, and fetal echoes also, because I said cardiac anomalies are very common. Then type 2 diabetes itself comes as a risk factor for preeclampsia. So to avoid all the complications of preeclampsia, preterm birth, FGR and everything, we start them on actually 150 milligrams of aspirin daily. Okay, starting preferably around 12 weeks. So rest, I want to, this one I want to know. You have to screen them for asymptomatic bacteriuria, okay, and vulvovaginal infections with all swabs and everything. You do it intensively in patients. And as I said, for vasculopathy, you should do the renal function test, the fundus, echo, okay, and intense fetal monitoring, that is applicable to both. Okay, these are special ones that you do extra for type 2 diabetes. Okay, and termination by 38 weeks. And during labor and postpartum, we need intense fetal monitoring. During latent stage, we monitor sugars every 2 hours, active phase 1 hour. Okay, and elective section indication remains the same. Diet and IV fluids during labor. So we avoid dextrose containing fluids. Otherwise, rest can be RL and MS scan. And always prepare for shoulder dystocia. Good neonatologist to manage all the new complications. Okay, and oral contraceptive pills should be very cautiously given. GDM, there is no problem, but giving it on a type 2 diabetes patient, always look for other complications, whether she had dyslipidemia, whether she already has a vasculopathy, all that has to be assessed before giving oral contraceptive pills. They are not the preferable mode of contraception in type 2 diabetes. Okay, copper T can be inserted. Previously, as I said, they were very afraid of the risks of infection using copper T. Now we can give it freely. It's only WHO class 1. Now, indications for medical termination of pregnancy. When do you want to terminate pregnancy in a type 2 diabetes mother? When she already has worsening vasculopathy, like already she's in renal failure, already she has worsening retinopathy, vascular problem, and all that. They are all indications for MT because we know for sure that they will worsen during pregnancy, and the health of the mother is always held above the health of the fetus. Okay, so these are the special ones for type 2 diabetes. So quick look on this. I think I have emphasized most of this here. Yeah, so these were my last two slides. Cover the case scenario quickly. So first one was a gestational diabetes mellitus with previous history of PCOS. So that was one risk factor. Okay, and now she's given a DIPSI. Okay, she's given a DIPSI and her value has come 150. Okay, so that is above the cutoff. So we have labeled her as gestational diabetes. So now, what are the risks of her anomalies? Now, it is given in the history that previously her sugars were told to be normal. So we are assuming her HbA1c to be normal. Okay, so the baseline risk holds for the same for this patient. So roughly around 3 to 4%. What's the role of metformin in this patient? Actually, there is a saying that like if you have started metformin for PCOS and she has become pregnant, you can actually continue metformin till at least 20 weeks and then you do the GTT. You can stop it before doing the GTT because metformin does not cause any major anomalies, okay, and provides good control during pregnancy also, and it gives a good glucose tolerance. So you can continue metformin through 5 months in this patient. So what are the associated complications antenatally and during delivery? I think I have covered. Go through mainly infections I want you to know, and macrosomia, shoulder dystocias, wound infections and all that. The postpartum health. So what is the routine antenatal care for this patient? We have seen the screening. How will you manage her? Okay, how many visits? How frequently you will screen for sugars and everything? I have discussed. Okay, and this one. So how will you counsel the patient? The important points I want to tell you is she is on glimepiride. So you'll have to switch her to good, compatible drugs like metformin and insulin. Okay. And then you have to start her on periconception and folic acid. Remember to start aspirin in this patient. Okay. And then, so you should also look at the HbA1c levels, bring it to 6.5 and below before conception, and all that has to be built in detail. Then you should talk about diet, exercise, ideal weight gain, and all that. So what is the risk of anomaly in her next kid? So this may be during this pregnancy, her sugars were deranged, and during period of organogenesis, her HbA1c could have been higher, so she ended up having cardiac anomalies in the fetus. So now if you try and bring her HbA1c levels to 6.5 and less, preferably less than 6, the risk of anomaly would tend to remain as normal, like 3 to 4%. Otherwise, depending on the HbA1c level, the risk may be higher. Okay. So what are the steps to be kept in mind to prevent another preterm labor in this patient? She requires intense sugar monitoring and tight control of glucose. Okay. And then should be screened for asymptomatic bacteriuria. Okay. Treat any urinary tract infection, treat any vulvovaginal infections in this patient. Screen them frequently for asymptomatic infections. Okay. Because these are the contributory factors to preterm labor. So other conditions causing recurrent pregnancy loss. This I will give as homework to postgraduates. Okay. So please read about AFLA, RH incompatible syphilis. What are the patterns of pregnancy loss in these? Okay. Criteria for AFLA and this is for postgraduates. Yes. So that's the end of my discussion. Thank you for the opportunity all for participation. Any questions? I'm okay for answers.
Thank you, ma'am, for imparting wonderful knowledge on how diabetes affects almost every woman. Almost every woman out there needed light on this topic, and indeed, women like you are a blessing to other women. Indeed, you presented in the best way possible, and thank you for your valuable time, ma'am. And a heartfelt thanks from Medusane and the entire medical community from us to yours. And thank you to Medusane for giving me this wonderful opportunity. Thank you.
Thank you.